Hello, and welcome to our webinar. We're just giving it 1 minute to let people get assembled, and we'll get started. Great. I'm Dr. David Nace, Chief Medical Officer here at Innovacer, and I really am thrilled to welcome you to this webinar today. Digital Patient Engagement, the Final Frontier in Patient-Centered Care. It's a really exciting lineup, and we're really excited about all the folks that have come to join this webinar. Very important topic. How do you engage patients? And in today's environment, how do you do that digitally? So, with that, no ado, let me introduce my guest panelists. First of all, it takes great joy in inviting my friend and colleague, Dr. Paul Grundy, founder of the Patient-Centered Primary Care Collaborative and Chief Transformation Officer here at Innovacer. Paul, welcome.
Delighted to be with you, and this is such an important topic, particularly in this era.
Absolutely, absolutely. And then more importantly, to talk a little bit more about some of the advances in this field is Blake Margraf, CEO and co-founder of CareSignal. Blake, welcome.
Thanks, Dr. Nace. This is so timely and fundamentally important as we move into virtual care.
Great. So with no further ado, let's get into it. So this is a very provocative statement, Blake. You know, the biggest question in my mind is, what do we mean by patient engagement? Blake?
I think everyone who says it means something slightly different. Let's start with the first word, patient. We're not talking about some platonic interaction here. For this to be patient engagement, not just a consumer interfacing with a business, there has to be something clinical. Next, we move to the word engagement, which means something actionable, right? A nudge that doesn't lead to anything and doesn't inform any clinical intervention is next to useless. So when I hear patient engagement, I'm looking for clinically relevant and actionable data collected that can inform care.
And Paul, have we always done a good job in healthcare of engaging patients?
It's really interesting. That brings me to my cat, Millie. You know, when we first started this journey towards population health and began the conversation around how do you engage your patients, I got a notice from my veterinarian that said that my cat needed an immunization. And I took that notice down to my GP and my primary care doc, and I said, how many women in your practice have not had a mammogram and you don't know about it? And he said, I have no idea how many women have not had a mammogram. I mean, you know, I would think that at least, you know, 15 years later, we would be at least as good at engaging our patient as my vet is with my cat. But, you know, with tools like CareSignal, maybe we're going to make some progress. It's an exciting time.
Absolutely, you know, and that's true. Most of the docs I talk to just don't know what's going on, except for the patient that's just walked into the room that they're going to meet with. So I think that makes this phrase all the more powerful, that if patient engagement were a drug, it would be the blockbuster drug of the century and would be malpractice not to use it. So let's figure out how we're going to do that in a contemporary digital environment. Let's start with you, Paul. You know, this pandemic that we've been, you know, dealing with for the past year almost has really started to change the environment of how we think about patient care. What are some of the issues we've seen with this pandemic?
So I think a lot of the things that we had hoped would happen in a world where you really have a population you're going to manage and you really have tools to engage them have been sped up through this pandemic. You know, necessity has sort of forced us to engage remotely, to engage more effectively and more efficiently. One of the wonderful stories that came out of this was I happened to be a healthcare ambassador for Denmark, and we use our ambulance employees there to engage patients. and when I was talking about that to Orlando Health, when they were trying to figure out how they could not only do telehealth, but actually reach out to the patients and engage them physically and also being able to draw blood and do laboratory tests and stuff, I said, you know, well, we use the ambulance service to do that in Denmark. So they called their local ambulance service. It turned out it was the same company that is in Denmark. And they're so happy with that, right? But there's just so many ways that you can more effectively engage a patient. On the island of Jersey, we use the postman. He goes to every home every day anyway. And so, I was walking with the postman around his area, and he was meeting with an 87-year-old woman. And his job that day was to fix her iPod so she could engage online. And he says, I've done this 27 times, but it doesn't matter because I'm going to be at their house every day anyway.
So Blake, with this pandemic, we've seen a high adoption, I think, of using telehealth and being able to provide care in different environments than we have before, haven't we?
Absolutely, and I think in that same vein, and perhaps even more strikingly, we've seen a willingness, in fact, a preference on the behalf of many patients and patient demographics that didn't consider virtual care a real option prior, and now wouldn't think of going back to in-person unless they really have to, which is pretty exciting.
So when we talk about patient engagement, there really can be a big impact, can't there? I think, Blake, just looking at some of the data and evidence here, what happens when we get patient engagement right?
When we get patient engagement right, we get clinical outcomes. And when organizations that are being smart about their strategies and looking toward the long term get clinical outcomes, they get dollars. So it's not that much of a logical leap to say that patient engagement is one of the most surefire paths to financial returns in a decent time horizon, especially for organizations that are taking on risk. And this slide shows, as a jumping off point, and Dr. Grundy, you've spoken to this slide shows that there are so many ways to get to that value. You don't have to follow one prescribed path where you just engage heart failure patients, though that's great. You can cover a broad spectrum of patients in a lot of different scenarios of care and create a lot of value across the board.
And Paul, what happens when we don't engage patients correctly?
You get butts in beds. Honestly, if you are effective at making sure you have the tools for, a person to actually take the medications that help them, a reminder, as an example, we've shown a 12% decrease in hospitalization. Just a little beep on their dispenser that says you need to take a pill. But there's just so many different ways that you can remind patients that they need to do what they do. When my wife was notified that she had not had her mammogram, and it reminded her to do it, it saved her life, right? That's as simple as that. It's just taking the basic tools that we have of reminding people, it's basically tell them what you're going to tell them before the appointment, do the appointment, and then follow up and keep reminding them. And the science around that is just really fascinating because, the way Amazon shops you, right? We now can tell that a woman with 3 kids is most likely going to respond after 8 on Tuesday if they work, because we can begin to see patterns with the kind of tools we have now. And then we begin to see that, if we tell them once, we get this response. If we tell them 3 times, we get this response. But, we piss them off if we tell them 4 times. Those kinds of aspects of utilizing these tools are going to be immensely important. But that's the real breakthrough. The real breakthrough is in healthcare is the behavioral economics of changing what a person does because you have the tools to help them do that.
Yeah, I think to your point, butts in beds, if we don't engage patients correctly, then we end up with lots of people at much later stage of their condition, in the hospital receiving care that could have been avoided. So let's talk a little bit,
right? Mostly the patient. It's good for nobody.
That's right. So let's talk a little bit about, thinking about when we should reach out to patients and how we think about that. There's this whole issue of high-risk patients. We've always done a lot of, work trying to figure out how to engage people with care management for people with high risk, which is a small percentage of the population. But then there's this issue of rising risk. So how do we think about the difference between high risk and rising risk? Let's start with you, Blake.
Sure, and I'll share a very quick story here that I think hammers this home. The chief medical officer of a large St. Louis hospital brought in a bunch of technology leaders. This was a few years ago now. And we sat down and he said, okay, I'm going to put in front of you, our list of the patients we need to support. And I was thinking, geez, okay, great. This will be, a compendium of, 5,000 people. It was a 21 patient list, 21 names that used that disproportionately high amount of the emergency department and other resources. And what this paper, this New England Journal of Medicine paper shows is that, of course, it kind of feels good to start with that super high utilizer group, but the real money comes when you focus on the rising risk part of the population. And that's exactly, I think, what a lot of folks are starting to open their eyes to, is it's hard because you have to use technology that can scale to all of those folks. And we're talking tens of thousands of folks for any given decent sized IDN. But if you do it, that's where you really bend the curve and you integrate under those two different curves and you realize there's a lot of savings created.
Yeah, there's a guy named D. Whittington, Dr. D. Whittington, University of Michigan. He's written about this for 25 years. And the problem sometimes with identifying those that are at high risk or the current chronic conditions or chronic, polychronic conditions is that they often become medium or low risk in a short period of time. And it's the rising risk that become the high risk. So Paul, I want to kind of come back to you and say, how do we think about this in terms of the way we think about risk? There's clinical risk and then there's other risks, like the social, economic, and environmental risks that a patient has.
I mean, this is so important. I mean, the pilots that failed when we kicked off those early patient in medical home pilots were the ones that only focused on the sickest few. And our experience at IBM when we looked at the data was those sickest few, only 4 of them were there next year in terms of, I mean, you're really missing the target for the high risk. But, it's so much more than just understanding their congestive heart failure. It's understanding their environment they live in. I mean, probably 60% of risk is understanding the dynamics of your total exposure. And that's so important. I mean, one of the things that we did with, we began to see in one of our customers, we began to see an uptick in hypoglycemic events in type 2 diabetics. We began to see that in a few zip codes and at the end of the pay period. They were running out of food, right? I mean, it's as simple as that. I mean, but if you don't understand the elements that you're up against, I mean, we all know that giving somebody some medication that live under a bridge, they're not going to do very well. But so you really, in order to get at risk, you really need to understand what's happening at that community level, down to the individual level in a zip code. What's going on that would allow you, particularly when you're going to be at risk for managing a population, when a person in a bed is a cost to you and not a profit anymore.
Yeah, this is such an important issue. Our friend David Nash, who has started the first school and now College of Population Health at Jefferson University, he often says the 2 biggest predictors of risk are credit score and zip code, and nothing clinical at all. Blake, in your work at CareFirst, how have you thought about this?
Yeah, so I think it's again, it makes sense that we want to tackle those challenges the same way we tackle challenges for more traditional health conditions, CHF, COPD, hypertension, diabetes. The problem is there is no cuff that tells you when a patient is feeling hungry. There's nothing to put on your finger that gives you a sense of someone being worried about paying for rent at the end of the month. So we have to rethink what it means to remotely monitor and engage patients, and we have to shift towards something that not only captures relevant data, clinically actionable data, but that does so for absolutely anyone, regardless of socioeconomic status, exactly to your point.
So it sounds like the key fundamental issues here are how do you collect data to identify patients that need some form of engagement, and then how do you then engage them and then educate them at the right point in time to really improve their health. Am I getting this correctly, gentlemen?
Yeah, and I think the point though is if you're going to focus on rising risk, you're not going to be able to use care managers, in the same way that you did for those 21 patients, right? You're going to have to automate that process. I mean, you're going to have to automate it at least as well as my vet does for my cat, right? I mean, you're going to have to be able to understand how to get information in a meaningful way that's actionable and that will be acted on, so that you can engage that patient. But it's got to be automated.
So, this raises the point on the third bullet here, which is, patient education is a significant part of pre, during, and post-treatment. So, like when we think about this, like what are the different aspects? It's not just when the patient's in the room and, in my days in family medicine would pick the chart off the door and say, well, who's here? And then figure out what's going on about them and then maybe educate them during the time I was in the room with them. But we really need to think about that differently, don't we?
I think so. I mean, you don't worry about a patient being engaged when you're sitting across from that patient in the room. You can definitely tell if they're not, right? That's another issue altogether. It's especially in that after visit period. I think folks are really, really curious about the lab results. But beyond that, you look at portal usage and it falls off to next to nothing. So I mean, this is a well-trodden concept of most of the care and most of health happens, in the 99 point many nines between visits. But what does that really mean from a patient engagement step? A slightly different lens that my team and I encourage our partners to use when viewing this is really pick your battles. There's the concept of the digital front door. I think that still suggests that the onus is on the patient to knock on that door. And most of the time, people don't knock until something has already gone wrong. I prefer the concept of the digital foyer. Again, portrait analogy. But ideally, you already have folks milling around inside your lovely home. And you can pick the ones that you need to pull deeper in to put in the right room to connect with the appropriate license level of care at the right time. You're not hoping that they pick up their hand and say, hey, my blood pressure's high today, let me talk with someone about that.
No, I really love this slide, and it really gives a much more robust framework for thinking about the different times, ways, and methodologies that one would use to engage a patient. I think what I'd love to do is just sort of check into our audience real quick and just sort of see, like, what are their key challenges in effective patient engagement today, given that framework. So for those of you in the audience, please use your chat box and go ahead and enter one or more of the following choices in terms of what are your key challenges with effective patient engagement. Now that we've been talking about it, like, is it the lack of a unified view of the patient journey through that whole pre, during, and post? Is it inability to scale your patient monitoring techniques? Is it an inability to identify and stratify your vulnerable patients based on having enough data and analytics to do that? Is it a lack of systems to engage a patient, like we just talked about, the digital foyer or patient portals and telehealth? Or is it a lack of just technology systems in general? So please put your answer in there and we'll get right to it. Let me ask Paul, when you think about your journey while we're waiting for people to answer, in terms of engaging patients. So where do you think the key barriers are?
I mean, I think that we did a study at IBM Research. Miriam Ball led that study, and we were looking at our employees who pretty high salaried. And what we found in a primary care setting was that 60% of them did not know a day after their visit what the doctor had told them. Seriously, right? So, I mean, I think a really important tool is, tell them what you're going to tell them, then tell them, and then follow up with reminders, to do the right thing, and particularly with medication management. I mean, tools that do that, I think are really important. But I think we have so many powerful ways now to impact, in a sort of behavioral economic sense, to do the right thing. I think that the other thing that's really important is that human side of us. If you're offered a chocolate bar or told that if you don't eat that, a year later you're going to get a tax reward, you're going to eat the chocolate bar, because short-term behavior outwins long-term goals almost universally. We are not logical. So we need tools to kind of help us, do the right thing, even though we know it's the right thing.
You know, Blake, I often think about my own experience as a patient. You know, I often, you know, will make a list of things to talk about before I go, and I go to the waiting room and fill out and yet another clipboard of information, then go into the room, and finally the doc will come in and we have a session, and then, you know, on my hands on the doorknob, and I suddenly think as he or she says goodbye, oh, did I remember to ask this? And then I get home and I forget what I was told. So, you know, it sounds like engaging patients really can use a step up, huh, Blake?
I think so. If there were an ICD code for doorknob syndrome, it would be one of the most most built out there. And you nailed it, right? There's a big difference between asking a patient something, asking a patient about something that matters to him or her, versus trying to shove new knowledge toward a patient. And it's so much easier to pull than to push in that case,
Yeah.
which is, you know, when you look at a lot of the literature, that's exactly where folks tend to converge.
That's right. So, hey, I see our poll results are done. So let's go ahead and pull up the results and see what we think.
So
Oh, yeah, Paul, what do you think?
yeah, I think that's right. I think that that's what I would agree with, the lack of a unified view. I mean, that the ability to get at, clean up, process data, and be able to have a plan for every patient, I mean, that is the third leg of the stool that I've spent my entire life working on, right? It's the ability to do that.
Blake, do you agree?
For heaven's sake, of course. And look at Innovacer's perhaps most fundamental innovation, where you're looking at the patient as one, as care, as something orbiting around each patient as an individual, rather than trying to carve out pieces of that. And frankly, I mean, it's pretty cool to see that folks on this call need the unified view, then need the systems to engage, because that's why we are both sitting here.
Well, let's get into talking a little bit more about a better framework to think about how to engage patients. So if we do think about this issue of data-driven, right, which is what you just talked about, Blake, you know, how do we think about unifying data from multiple sources, not just clinical sources, but social, environmental, economic, and many other sources as well? How do you identify not just patients at risk, but also patients at rising risk? And obviously that'll require some of the modern techniques of artificial intelligence, machine learning. And then how do you then think both how to monitor them at home or in their environment, and you know, in between these office visits, and then also how to engage them, particularly when you are noticing things around the monitoring of care. And then lastly, how do you intervene? And obviously we've learned a lot about it in the pandemic with virtual care. So let's break this down and kind of get into it a little bit more. Paul, you mentioned, you know, the work you've been doing at Innovacer and unifying data. You know, what do we mean by unified data?
So I think that's the secret sauce. It is the ability to take data from disparate sources, social determinants of health, claims data, clinical data, state exchange data, take that data and understand what each little bit of data is saying, and then standardize that into some sort of universal terminology so that you're using the same reference point. Cleaning that data up. I mean, literally, it's exactly what Google does when you're using their map device, right? I mean, it takes all these amazing amount of information and this just tells you, turn right. And after you've done it for a while, you figure out, you know, I probably better listen to this because they know that there's an accident there that I'm going to spend an hour in if I go straight. But I mean, it's just making it clear. But I think that fundamentally my difficulty over my career is that the information age has failed us in healthcare. I mean, we can shoot a rocket to the moon and bring somebody back safely by programming a computer. But in order to manage 100 diabetics or help you manage your healthcare, it's a gazillion times more complex than that. So I keep thinking, thank God we've left the information age and we've moved into the age of intelligence, because we now begin to have tools to look at patterns differently and put it together differently and really begin to help that patient understand and be reminded and continue to be reminded effectively of engaging them in essence to do the right thing.
Yeah, and I think it's also important to not only think about that, but also think about the quality of data. Blake, I know quality of data has often been an issue in the past, hasn't it?
It has been, and it will continue to be. And if we define quality as clinically relevant and actionable, the bar gets pretty darn high, because big data is great once you have ground truths and once you can train models on it. But starting off, I mean, it really is quality that counts.
So once you get data unified and get high quality data and start to think about using it, let's go back to this issue about identifying the right patients to engage. So, Blake, how do you think about this in terms of using this data in terms of identifying issues around rising risk or those at risk?
Yep. And I think this is where it's really a privilege to see what Innovacer has built. We work with a lot of different groups, and I can now say from experience that what you've built is the leading type of program for this use case, because you're not only looking at this from a clinical risk perspective, you're also focused on what allows for the greatest financial return. And let's be real, right? If we just look at rising risk from a clinical perspective, a lot of groups might not be able to justify purchasing new programs that will benefit them both clinically and economically in the longer term. Whereas if we roll in that financial return component, suddenly we can afford to be smart, but also do what's right for the patient.
And Paul, when we think about identifying those patients, right, we also think about getting insights, not just looking at data. We're all swamped in data. I talk to a lot of my colleagues, CEOs of hospitals, as I'm dealing with a data swamp. I'm overwhelmed with data. How do we convert data into insights? What do we mean by that?
I mean, that's really key. I mean, again, I'll go back to that story of identifying a pattern that AI can do, that allows you to understand by looking at that pattern that, an insight is that I'm most likely going to reach that person with 3 kids who works after 8 on Tuesday. I think that the other element of insight is, that human behavior that needs to be supported in an effective way. I mean, when we did a study with our own employees some years ago at IBM, we offered them a pedometer to tell how often they walked, and rewarded them for using it. But when we put a teammate around them that could help engage that person with some insight about their own behavior, that meant to them, and we were much more successful. I mean, I don't know if I explained that very well, but I think it's just, the ability to get the right information at the right time to a patient so they can act around something that would be useful to them.
No, this is great. I'm really helping to break this down and understand it better for myself. So being able to bring data in from multiple different sources, being able to unify that, ensure a high quality of data, and then getting insights about patients' behavior to best set up yourself to engage them. And I think I'm hearing that pretty clearly. So Blake, let's get into the sort of like magic that you've done at CareSignal. You've really started to think about how do we then monitor a patient once we've identified how to engage them.
That's it. And not just monitor the individuals with congestive heart failure and COPD, but look at folks, perhaps new mothers on Medicaid that might need support with adherence to breastfeeding, support folks with behavioral health challenges from depression to opioid dependence, support folks with challenges around social determinants of health. And by the way, that's a nearly infinite list with at least 12 really frequent elements, but there are a lot of different challenges in SDOH. And of course, for each of those things, Dr. Grundy, it's exactly, in my opinion, what you just said. It's ask the right question at the right time to inform the right type of care. Because without that, you can know who's generally high or rising risk, but what are you going to do about it?
Okay, you've got me really, really interested on this slide here. What do we mean by deviceless patient monitoring? Because most of us think about patient monitoring as a device in the home that sends signals, right, to a monitoring device.
Exactly. And first, let me say that technology is awesome. If one of my parents were diagnosed with a condition that warranted really intensive, you can, bet your bottom dollar I want that type of program. But for all of the folks for whom that's overkill, right now there's this giant gaping hole, right? The next thing they have is patient engagement or some kind of portal that nobody uses. Deviceless sits between the two, and by definition, deviceless remote patient monitoring means remote monitoring that can be conducted with only the devices that an individual already owns. So I'm talking cell phone, flip phone, landline phone. If you don't own a device, we still have to work with you. So we're going to go to a concerned caregiver. But it means that, and my team jokes about this, they hate it when I say it, it means that nobody can escape care signal. We're that darn accessible.
Well, Paul, I think we've learned over time, right, that most people have something. Like people have either a cell phone or a smartphone, or many people have like a Fitbit. So Paul, isn't this what you see now, even in medicated patients? I actually think sometimes you see homeless people with a cell phone.
Yeah, and with the 300 gazillion satellites now that everybody's going to have a signal no matter where they live in the world. It's just going to increase in terms of that. But yeah, it's very rare to have folks that don't at least have a cell phone at this stage. I mean, I grew up in Africa, and I think probably the most impoverished nation in the world, Sierra Leone, and the cell phone penetration is incredibly high, right? But I always think of the deviceless stuff. Is that experience in Jersey where the postman is, but Meals on Wheels. I mean, you can think of 1,000 ways that you can engage a patient with but boy, to have these kinds of powerful tools, this is the third thing I think that's shifting the way we think. It's the unsustainable cost of healthcare, and it's the ability to manage and engage patients in such important and different ways.
And I think there's this whole issue of real-time data. People have their health 24/7 when they're sleeping, when they're awake. It's not just twice a year when they're in the doctor's office and they fill out that clipboard. Blake, how do we think about, how to manage all that data if we're collecting it constantly? And do we do it intermittently? Do we do it continuously? How do we think about that in terms of, real-time access?
In terms of real-time access and data management, I think the first step is again, pick your battles, set thresholds, decide when to intervene with whom. Because as you discussed previously, I think Dr. Grundy alluded to this just a little bit earlier, you can't scale the traditional care management model to all of the individuals who need it and who will need it as we continue moving down the population health sliding spectrum. So in short, organizations already have great relationships. They already have a sense of standard operating procedures. They've established some really strong standards of care. Now we have to figure out what it takes to escalate a patient to that category of needing clinical intervention.
So let's break that down a little bit, and that's really this next step of really engaging the patient, right? Paul talked a little bit before about being able to understand through data the unique aspects of a patient's behavior and the kind of way to interact with them. But it's two-way communication, isn't it, Blake?
It has to be. When's the last time you had a really good date where just one of you talked the whole time? It's absolutely two-way communication, and it's two-way communication at the right time and with the right license. Because frankly, Dr. Nace, not everybody needs your level of expertise and frankly your cost all the time. A lot of times, a licensed clinical social worker can be just as positively impactful. So you're not sacrificing anything and you're only making more money.
So how do you think about that, Blake, in the work that you're doing? How do you think about like when to intervene? What data do you have or information do you need to make an effort to intervene? And then how does a patient interact with you once you intervene?
Sure. So maybe a great example here. Let's look at CHF. Because I would bet that of the folks on the call, at least half have that circled on a Post-it somewhere nearby. right? So for CHF, some organizations want to intervene if there's a more than 3% change in weight suggesting water retention. Some might have a 5-pound rule. Others might do it just based on qualitative symptomatology like pedal edema or nocturnal dyspnea, right? All of those are valid, right? And using a modified Kansas City questionnaire, you can probably hone in on capturing a lot of those responses, right? But it's going to be different for each organization. It all starts though with exactly what Innovaccer has to offer, which is circling the relatively risky individuals with CHF in the first place, and then whether it's Care Signal or another remote monitoring program, but I definitely prefer, Care Signal, but whatever it is, right? Then you start capturing those patient-reported outcomes, those quantitative biometrics from the individual over the long term, and then just to tie that feedback loop closed, when someone crosses that threshold, they've retained 3% body weight, their legs felt puffier than usual, their ankles feel swollen, whatever it is, then they're not going to you, Dr. Nace, right? Frankly, it's not worth it just yet. Instead, they're going to go to maybe a hub and spoke care management unit. And by the way, again, Innovaccer not only has the population health stratification, you also have the care management tool, which is crazy. You have both sides of the spectrum. And that's where the meaningful clinical interaction can occur. Hopefully keep that patient way off before they wind up needing to go to the ED. So it's a story that everybody understands, but now there are finally the mechanisms in place to mean that it doesn't have to be a story with a bad ending.
Well, Blake, you really identified this whole issue about how do you then use the technology to engage the patient as well. We think about it as an application like InConnect that you have that so they can download on their smartphone and have that access. So we've talked a lot about remote monitoring and wherever the patient is, right? To engage them with whatever devices they have. It reminds me of the work environment of the past couple of years. Bring your own device to work. And then, how do you manage the patient experience? Paul's talked a lot about, identifying, what works to engage the right patient. But Paul, I'd like to get your thoughts about this. How does this help to change the workflow and the workload for clinicians?
So again, I think that what we saw with a hand phone, a cell phone, and a monitoring device with diabetics, when we just scanned their lower extremities and could identify the day that they had a lesion in their lower extremities, we were able to prevent 60% of amputations. I mean, that's a change in workflow. It greatly benefits the patient to continue to have their limbs, but I don't think a surgeon wants to spend a lot of time doing an amputation. I think that's a huge amount of work and resources that could easily be prevented. And in fact, we can show that it can be prevented 60% of the time. It's as simple as that, right? As we said, most everybody has this, and if they don't, it would make sense to buy them one. but that's just an example.
And it really illustrates the kind of things we're trying to prevent. Blake, if I go back to that framework about engaging before an office visit, during an office visit, after an office visit, and I give you that example of, when I was in family medicine, maybe 2-3 times a year, or 3 times a year for somebody with chronic illness, I might see them when I'm walk into the room. How does this change in your experience at Care Signal in terms of the workflow of the patient with the physician? Like engagement, like how does it change their day-to-day operations? Does it make it more efficient? Does it help to improve their ability to care for those patient population to prevent the kind of things that Paul just described?
It does, and if there's a single fundamental reason, it would be that it escalates or elevates folks to top of license on the clinical side, of course, right? And it's when you think about it, really, a patient has a license too, right? It's not a medical license, but if you're calling someone every day saying, "Hey, how are you doing? That's going to burn someone out pretty quickly. That's below the top of their license. Patients can report certain types of symptomatology just as effectively as some clinicians can act on it. So you're really elevating everybody.
So that really helps me with this. So not only does it allow greater connectivity around the clock, but it also broadens out the care team itself and allows more data to be available and makes their physician a little bit more efficient in their work in terms of taking care of patients. Let's use this opportunity to check in with our audience once more and say, you know, what are the current patient engagement strategies that they use in their organization? So once again, please use the chat box to answer this and select just one of the following questions. So in terms of your organization, where you work today, your practice or your organization, are you using a Wi-Fi device-based remote patient monitoring? Are you using some form of automated patient outreach that's automatically generating outreach efforts to the patient? Are you using a smartphone application like we have here at Innovaccer with InConnect? Are you using a smartphone application to regularly engage, collect information, interact with the patient, and monitor them? Or are you using a call center in terms of your engagement strategy for workflow management with your patient? So these are a diverse set of options, and probably could think of a lot more. While we're waiting for the audience to sort of give us their impressions here, Blake, let's check in with you. Outside of the work that you've done at CareFirst, again, outside of the work, what have you seen across the country in the way organizations and practices have thought about patient engagement?
Yep. First is deciding how to deploy their current care management capability. Before any technology comes into the equation, organizations that I've seen that have been successful independent of their technology have leveraged some kind of hub and spoke model instead of trying to scale every individual care manager directly kind of interfacing with patients.
Well, before you progress, say more about what you mean by hub and spoke model.
Thanks for catching me there. So in short, and that's a great question because it's a little bit counterintuitive. Hub and spoke means that the hub at the center of this conceptual wheel is a much less expensive, lower license, or perhaps even someone like a medical assistant who's interfacing with the technology or multiple technologies for remote monitoring. The spokes then are the individual higher license care managers, perhaps RNs. Sometimes you see a few NPs sprinkled in, and I'm sure most folks listening are familiar with the pod model, where you have some stoichiometry of MAs, LCSWs, then RNs, then a few NPs, then one physician who's able to service usual multiple pods. The hub and spoke allows you to scale even beyond that model by putting a single person or just a handful of people in charge of a huge number of patients that are scaled with technology.
No, that makes sense. And Paul, your work when you were at IBM and even here at Innovaccer, what have you seen in ways that organizations and practices engage patients?
You know, I actually took the leadership of Kaiser to Denmark to show them what we did there. And the core of that was based on a relationship of trust. And identifying who is the healer to the patient, and then creating a scenario in which, you know, whatever happens, it's done in the name of that relationship of trust, seems to be more successful than any other way. So, you know, in that call center in Portland, if you have a problem and you're anywhere in the Kaiser system, what's going to happen is when you call in, they're going to say, I see your doctor is Gonzalez. I know he cares about you, and you know, but to link the information into a relationship, I think makes it really powerful, because you know we have that social need as a human being to have a relationship-based care model. I think, and I think that's probably the foundation of what makes this successful.
You brought up a great point, which is no matter what methodology you're using here for patient engagement, it's knowledge about the patient and helping to build that relationship through trust, that you know them and understand them. So it's so critical. Hey, I see the poll results are done. Let's go ahead and pull up the results and see what people said. Well, this is interesting. Paul, what do you think? Actually, there's hardly anybody saying they're using device-based remote monitoring.
Yeah, I think that a call center like what I just described with Kaiser is a pretty interesting model. But I think, my experience with that both at Kaiser and UK and Denmark is that, if you can link that into a relationship of trust with the devices and the tools, et cetera, you're going to be better off.
Blake, I think this is interesting. We talk a little bit about smartphone apps and devices, like very low responses here. What do you think?
That's hard. It's really hard. I think in a way that's appropriate. You have to match cost with acuity. So it makes sense to sync really high cost solutions into the high utilizers. But again, now exactly as we've touched on in a few different ways, it's all about scaling to the rising risk.
Yeah, and it sounds like call center seems to be the methodology of today for most folks. So what I'd like to do is just sort of move on, Blake, and hear a little bit more. We've been talking about your work at CareSignal. Tell us a little bit about, what it is you do and more about this deviceless remote patient monitoring.
Absolutely. So once we've identified using the Innovacer population health capabilities, the eligible cohort or cohorts of patients, the folks who are in that rising risk bucket, who, if supported, can potentially avoid a lot of adverse clinical outcomes, create a lot of value. Once that's identified, then CareSignal takes that list, we enroll those individuals. Actually, we do that by hand. Sounds crazy, but that's a manual process. Our team this week will make many tens of thousands of calls to individuals all across the country. And then those patients start receiving simple condition-specific messages, predominantly questions, because it's way easier to ask a question than to shove information down someone's throat. And if something starts to go wrong, then our partners are able to use their care management solution, Innovacer's care management solution, to intervene in a scalable workflow. I would point out, normally we have a ton of logos of different cell carriers here. Because we're using text messages and phone calls, in addition to there not being anything to even download or log into, we have relationships with all the big cell carriers, so that Dr. Grundy, you mentioned, people who might be experiencing homelessness, right? If individuals don't have unlimited cell plans, we can still send and receive messages to their phones for free from that patient's perspective. So just accessibility, accessibility, accessibility.
Yeah, and I really like the fact that you've been published in a number of peer-reviewed journals. Sounds like you've had some evidence that we'll probably get into in just a second. Say a little bit more about this pay-as-you-go. What do you mean by that?
Yeah, so the industry acronym on the telecom side is FTEU, or free to end user. And if you do a dance and have the right relationships and spend a lot of time, then essentially, instead of being charged against a patient's cell plan, or worse, going.
And, Paul, it sounds like we may have lost Blake there for a second, but Paul, I see this example here on the right about some questions. This seems pretty user-friendly, doesn't it? I
think so. I mean, I think that this is something that, my mom could use, right? I mean, it's in her 90s. Yeah, I think this is very user-friendly, and I think that's the key is, and it was interesting going back to that poll of how many people thought that people use devices, but I think many people don't understand that we do.
Let's check in. I know Blake was talking a little bit about the workflow here. Blake, did we lose you, or let's just check in with you?
Hopefully I'm back. There's a lesson in here about me not being able to use technology or something like that.
No worries. Yeah, walk us through this workflow then.
This is you can't, in order to make a strategic decision, it all starts with identification. If you jump right into trying to monitor everyone the exact same way, that's a recipe for probably a bunch of bad patient experiences, as well as way too much cost. Once you have identified, then it's all about that remote monitoring. That can be done any number of ways, right? It's not just CareSignal with deviceless remote monitoring. It's also a suite of devices. It's a digital front door for folks that are already stable, and maybe you even have a fourth solution for the brittle well within a population. And then there's the intervention. And by the way, take heart, essentially, for all of the healthcare organizations, because this is what you're already the best at doing. This leverages relationships, clinical expertise, and the infrastructure that you've built over the past decades. So even though it seems like so much we're saying here is you're going to have to change, adopt new things, spend new money, it's not. All of this allows you to put your best foot forward in the way that you've already built it up.
Awesome.
No, that makes an awful lot of sense. So I think, when we take a look at all of the different aspects of, remote monitoring, this is not just congestive heart failure, right? It's a broad plethora of different conditions and, risk factors that one needs to think about this.
Yep, that's my favorite go-to here. Let's call out one that was motivated by the opioid crisis. We have opioid management, which is in the center there, top, and the third bullet down, I think. Opioid management helps newly prescribed patients avoid becoming dependent by closing that feedback loop in their utilization for those weeks or at most a couple of months after that new prescription has been made. Makes total sense. Obviously falls in the preventative medicine bucket. And if you were a patient, why would you want to play Russian roulette when you can avoid it? And then of course, a lot of these are so self-explanatory. It's things that are already on every organization's strategic roadmap.
Paul, when I always think about the early days of disease management, right? These ones in the top left, diabetes, hypertension, heart failure, COPD, these were always the big ones people focused on. But there's a lot of low-hanging fruit here, right? For things like behavioral health issues, depression, social determinants of health, just being able to outreach, and then also reminders for things like checking on your screening for cervical cancer, for breast cancer, etc. There's a lot of low-hanging fruit here, it seems to me. Paul, isn't that right?
Absolutely. I'm just looking at this list. I mean, like fall risk, right? I mean, a fractured hip in somebody in their 80s is a death sentence. And this is a device with a scan. You can look around and you can see that there's a shag rug that needs to remove. There's ways to really begin to engage patients around. I think of medication management. A simple device in Denmark, when you get chronic disease, you push it through the foil and let you know. And then you apply behavioral economics. We know that taking something away from somebody is much more stimulating than giving them something. So, we say if you don't dispense your pills, it gives a little chirp and reminds you. And if you still don't dispense it, you're going to lose your chance at the lottery, right? I mean, but there's just so many ways that you can utilize these tools to make a difference in somebody's life. And again, decrease the amputations by 60%.
Absolutely. So I think the key, and there's so much work to do here and so much opportunity, Blake, the key is how do you use this to scale, right, beyond these chronic conditions? So what have you learned in your work in terms of being able to scale?
Make sure you use the same team for all of it. The problem that we're solving is not a behavioral problem and then a maternal problem. The problem is a remote monitoring problem. And for groups that centralize that remote monitoring team, whether it's through an existing or perhaps a new digital care management capability, that's a way more successful. That's a winning strategy. Don't try and piecemeal it out across different service lines the same way you would medical specialties.
What's interesting, I'm actually been screening the questions that people have been putting in here. It's very interesting. So I'm going to use this opportunity with this slide to actually ping some of these out. So first one is very interesting, which is what are the key issues around using technologies like software, IT gaps, and establishing really good engagement with portals, applications, etc., and being able to actually manage this close to 100% of the time, the idea of patient engagement?
I can start with a small piece of that, and I'm curious both for your perspective and Dr. Grenda, yours as well. But it all starts with that first point of exposure. When a patient is first introduced to a new program, whatever it is, if it's high credibility and if it leverages the existing clinical relationship that that patient has, the probability of adoption and retention is extremely high. However, if this is another one of those bulk emails with another login portal where you have to do stuff without knowing what the benefit is to you with no prior warm-up, I mean, of course adoption is going to be lower, but unfortunately that's how a lot of programs are rolled out.
And I think you've actually answered the question earlier, but there's another question that came in here is how do we cross the barriers of different IT systems, different computer systems being used by different practices in each level of care? How do we cross those barriers? Go ahead.
Oh, sorry, I was going to say that's what Innovator is all about. Integrate not around the technology. Epic doesn't have feelings, right? They don't care if you wrap yourself around them. Integrate around the patient. Make the patient the one true center.
Sure.
And I think Paul, that's what attracted you to sort of this idea that we've done at Innovator is the idea of patient-centered care, right?
That's exactly right. I mean, it's so important that this tool be provided with a sense of, I care about you. I have a relationship that means something to me as a relationship with as a healer to you as a patient, and I care enough about you that I'm going to help you really have a better life by making sure that you don't have an amputation, or you don't end up in the hospital with congestive heart failure, or you don't kill yourself because of your depression.
Yeah, it's very interesting. Before we go on to hearing a little bit from Blake about some of the evidence of what they've been able to show using this combination of deviceless remote monitoring and then also using the Innovator information platform, I'm going to use this quote. It's throwing out a question that came in from the audience. I'll read it directly. I don't think the information age failed healthcare. Providers have refused to consider the benefits of technology. Status quo has been king. Few truly innovative providers have been identifying use cases to play with AI, MI, analytics, and data. I think that has changed with this pandemic. Don't you both agree?
Absolutely. It sped it up. Very cool.
So with that, Blake, why don't you share a little bit about some of the impact you've seen with the work that you've been doing at CareSignal?
Well, if you'll indulge me, actually, just today we found out that we received our 12th peer-reviewed journal publication. So that was with a colonoscopy intervention that we did in partnership with the VA. But let me give one example, right? Because this is not a feather and cap kind of thing. We're not doing this just to feel good about ourselves. We're doing this because we have to go through 5 or 7 or sometimes 10 iterations on a product in order to drive the outcomes that we want to drive and be able to publish something really cool and exciting. And a great example of that is in the upper left. We showed a more than 60% reduction in all-cause hospitalization risk. That was in a prospective randomized controlled trial, more than 160 patients. Now, here's a thing that's a problem. When you use any new technology to monitor patients, just the monitoring results in an improvement. In addition to that, you have a massive regression to the mean problem, where folks that started off as sick get well, and then the company takes credit for it. We controlled for both of those. The prior, which is called the Hawthorne effect, we had a placebo control arm where patients received the same questions but no intervention as a result of responding to those questions. And that 62% all-cause hospitalization risk reduction was versus the placebo control. And I could literally talk for 3 more hours on all of the other trials and the reason that we designed them the way we did. But that's I think the role of real research. And that's how, go back to the first quote actually, Dr. Nace, that's how digital health and patient engagement, remote monitoring in particular, becomes the standard of care. It's through the evidence of its clinical and financial returns. And that is how eventually we will be able to move the industry forward, because at that point, it really should be a suable offense if the industry leaders don't use it.
That is so very, very cool. And I think the key has been in our collaboration is getting all the data together in one place, being able to unify it, making it high quality, and then being able to allow CareSignal to do its job. So this has been a great webinar. I've really enjoyed the discussion, and I've learned a lot, which has been great. And I hope that those of you in the audience have enjoyed it as well. We truly want to thank you for attending this tremendous webinar. And I also want to thank my 2 panelists, Dr. Grundy and Blake. Thank you both very much for attending.
Thank you. And Blake, I want you to come back and do 2 more hours on your outcomes.
That's right. All right, with that, this concludes the webinar, and we will follow up with a copy of the slide deck and some information if you're interested. Once again, thanks for attending. This concludes the webinar.